Good afternoon, everybody. I think we'll go ahead and get started. For those of you who don't know me, I am Renae Barger, Associate Vice Chancellor for the Health Sciences Library System, and I have the privilege of welcoming you to our interprofessional panel of experts today that has been put together in conjunction with the National Library of Medicine exhibit, For All the People, A Century of Citizen Action in Healthcare Reform, that's currently on display in the library. There is a reception after this panel presentation for you to view the exhibit in the library and to have some light refreshments. It will also be on display through October 2nd, so if you don't have an opportunity to join us after the panel presentation, you can still have a chance to look at the exhibit. Before I introduce our moderator, I would like to first express my gratitude for the Library Exhibit Committee who put together the exhibit, this wonderful panel of experts, expert moderator, and the reception. And so those of you who are involved in the exhibit committee at the library, would you please stand to be recognized? Okay, without further ado, I would like to introduce our moderator, Dr. Tina Batra Hershey. Dr. Hershey is the Associate Professor and Co-Director of the MPH and JD MPH programs in the Department of Health Policy and Management at the School of Public Health. Dr. Hershey is a healthcare lawyer by training. She teaches courses on health policy and management, health law and ethics, and healthcare fraud, abuse, and compliance. Her research interests include using legal epidemiology to examine law and policy issues related to the delivery and quality of healthcare services, legal preparedness, and health equity. I'll now hand the program over to Dr. Hershey. Thank you.
Good afternoon. Can everyone hear me? Excellent. Well, I'm happy to be with you today. As just mentioned, I am a health lawyer by training, so I find this topic fascinating and perhaps more fascinating than some of you. In particular, thinking about the Supreme Court's opinions in this space. But it is my honor to introduce our panel. We are proud to have panelists from all the schools of the health sciences. So I will begin with Andrew Dierkes, who is a registered nurse, health services researcher, and assistant professor at the School of Nursing. He studies the impact of bedside nurses on patient outcomes and teaches undergraduate and graduate health policy courses. Our next panelist is Julie Donohue. Julie is professor and chair of health policy and management in the School of Public Health. She's my chair. She is an expert in Medicaid, behavioral health, and pharmaceutical policy. Next, we have Nancy Gauvin, who is the Associate Dean of Equity, Diversity, Inclusion, and Community Engagement for the Office of Equity, Diversity, Inclusion, and Community Engagement, OE-DICE, in the School of Health and Rehabilitational Sciences, or SHRS. Additionally, Dr. Gauvin is an assistant professor in the Communication Sciences Department within SHRS. Dr. Gauvin's research focuses on health equity and access as it relates to allied health sciences and conducts research in her lab called the Health Equity Access Lab, or HEAL, which is part of our OE-DICE office and research. Next up, we have Max Hurwitz, who is a physician in the Department of Physical Medicine at the School of Medicine and Rehabilitation and Assistant Medical Director of Street Medicine at Pitt. Adriana Modesto serves as Assistant Dean for Diversity, Inclusion, and Social Justice at the School of Dental Medicine. Adriana's work centers on a crucial yet often overlooked aspect of healthcare, oral health education. She has tirelessly worked to enlighten underserved communities about the vital link between oral health and overall well-being. Her efforts have helped countless individuals understand the importance of dental care as an integral part of their general health. Terri Newman is a pharmacist and assistant professor at the School of Pharmacy. She completed a Health Economics and Outcomes Research Fellowship at Pitt Pharmacy and her Master of Science at Pitt School of Public Health. As a pharmaceutical outcomes researcher, her work centers on optimizing pharmacotherapy outcomes by addressing treatment access challenges and gaps in the use of disease-modifying therapies for individuals with sickle cell disease. So please welcome our panel. So just briefly, I'll go over the format for today. I'm going to be asking questions that we formulated together as a group. Not every panelist will answer every question in the interest of time. And then at the end, I'll open it up to audience questions, and it'll be your chance to ask our experts your questions. So I'm going to dive in with our first question. And not surprisingly, it's a little bit lawyer-like. But what impacts on underserved communities have you seen from health reform efforts like the Affordable Care Act, Medicare, Medicaid, and the like?
I think I'm going to kick things off. I'll move this giant microphone stand closer to me. Can you hear me okay? Okay, great. So I think it's exciting to be connected to a sort of 100-year profile of the history of health reform efforts. We really try to bring history into our classes and teach our students that the ACA was not the first crack at health reform in this country, far from it. I think the main thing that has changed with Medicare and Medicaid in the Affordable Care Act is that each has taken an incremental step towards universal coverage and towards giving people health insurance. When Medicare first came into existence in 1965, the year before it was passed, fully half of the elderly lacked health insurance. Now, 2% of the elderly lack health insurance. Before the Affordable Care Act went into place and its major coverage provisions were implemented in 2014, 18% of the non-elderly population was uninsured, and now that number is around 9 or 10%. If the Medicaid expansion part of the ACA were fully realized, we'd be down at more like 5 or 6% uninsured. But there are 10 states in the United States that have refused to expand Medicaid under the Affordable Care Act. Those insurance expansions come with a couple of broad impacts. One is the intended effect of giving people access to care and improving their health. But the other effect is improving financial security. And that's something that I think we in healthcare and public health often forget about. The financial security aspects of having health insurance in many ways are just important as the healthcare access for improving outcomes. We know from studies, about 600 so far, studies on the impact of the Medicaid expansion component of the Affordable Care Act, that it has reduced the number of uninsured. It's increased the likelihood that people have a usual source of care. It's increased our utilization of preventive services, but it has also reduced crime. It has had employment effects. So there are many effects of health reform outside of healthcare delivery that really need to be considered because these are anti-poverty programs as much as anything else.
I think I can add a little bit to that. For example, one of the things that I've noticed through my research is that under the Affordable Care Act, the Innovation Center, the Center for Medicare and Medicaid Services created an Innovation Center. And their priority was to kind of improve the way that people can access novel drug therapies, improve quality of care, and cut down their prescription drug costs. And so with something like sickle cell disease, we see how that's made, well, it's going to, if it's implemented, which it's on its way, well, we see how that's made an impact in that disease state. So for example, one of the models that was created out of this was the cell and gene therapy models. And sickle cell disease is the first target area for this. And so this is essentially CMS is going to work with manufacturers and state Medicaid systems to devise outcome-based contracts, outcome-based agreements. So what we'll see is that individuals with sickle cell disease, which 60% of the population is covered under Medicaid, they are going to be able to have access to these innovative gene therapies, and they're working out ways in which it could be affordable for them. So I think just to piggyback off of that is, seeing how incremental changes, like we've discussed, like this is such a huge stride for the sickle cell disease population, but this was something that was implemented through Congress, and we see how it's going to impact a community like sickle cell disease, which is going to be the first pilot of this, and models are set to launch, I think, in 2025. So
it's very exciting. So something that's been alluded to just in these two answers, we're talking about costs. And so one question can be, how do we pay for care for the underserved and for the communities that we just talked about?
Start again?
Sure.
Okay. So I think we pay in kind of a couple of different ways, and one of the things I often do in my class is have people take out their pay stub and look at the taxes that are deducted for healthcare programs, and talk about the financing. So Medicare is federally financed. Medicaid is financed jointly by the states and the federal government. Medicaid is the biggest safety net program. It now covers about 81 million people, and it accounts for about 9% of the federal budget and 27% of state budgets. If you look at our safety net providers, hospitals, health clinics, other providers that are serving low-income populations, Medicaid is a huge source of financing for those providers. And one of the challenges that Medicaid faces is that the primary way it keeps costs from rising is to keep provider reimbursement rates quite low. That can have an impact on access to care among low-income populations. Other sources of funding are grants from the federal government to health centers directly to provide care to low-income people who may not have health insurance, so that care goes uncompensated. So there are grants to federally qualified health centers, community mental health centers, and other safety net providers that are critically important for keeping the doors open and keeping healthcare delivery going for low-income populations, even those who have health insurance.
I just would like to add, and bringing a little bit to the dental side of the cost, it's very costly to have payment for dental insurance. So there are other ways of being creative. For example, we could partner with nonprofit organizations, and I can give you a few examples here. In Pittsburgh, for the Hispanic population, we have Casa San Jose. We have Latino Community Center, and they pay for the cost of dental treatment. They also help for this. Sometimes immigrants, sometimes they are second generation living here in Pittsburgh. They can also apply to have the dental insurance. So there are different ways we can partner with industries. We can do other more creative, and especially for dental, there is a high need for Medicare providers, especially in the rural areas. So we can use mobile units, we can do teledentistry, telemedicine. So we sometimes need to be creative. And more recently, we have a lot of refugees in Pittsburgh, and we are working with the government to bring this refugees so we can provide dental treatment.
Thank you. So you brought up telehealth, so I'm going to jump ahead to our technology questions a little bit just so we have some continuity. So how can we harness technology to benefit care for the underserved, particularly thinking about our rural populations?
So can everyone hear me? Awesome. So I use telehealth. And so I've been asked to kind of talk about how that has impacted the care for the community that I care for. I'm a rehab doctor, and I care for people that have predominantly amputations. And there's higher rates of amputations in some communities, particularly rural communities, and communities that have lower income zip codes. So that means we have areas that don't have access to rehab doctors, areas that may not have access to trained therapists, but they have higher rates of amputations. And so we have to figure out a way to kind of care for this population. And so locally, what we've done is use telehealth in partnership with local therapists and local partnerships to try to create clinics that are similar to what we would have in Pittsburgh. Telehealth can be awesome in improving access for the kind of medical care that we would expect to happen here in Pittsburgh. But even with telehealth, there's not great access, right? You have to have, particularly if you want that telehealth appointment to happen in somebody's home, they have to have high-speed internet, or they have to have a device that can work with telehealth, and they have to have the ability to manage that device to work with telehealth. And so some systems have done better than that with that than others. For example, in the VA, they do a great job with telehealth. They send out iPads to their vets. They train the vets on how to use the iPads. And if they don't have access to internet, they get them to a facility within their community that does have access to high-speed internet. I'm not lucky enough to work in one of those facilities that has that. And so how do we kind of work within those challenges? And some of that is just getting as creative as possible, asking patients to go to someplace in their community that does have high-speed internet. Maybe we do the appointment at a library. We do the appointment at a coffee shop, outside of a coffee shop in a car using their internet. Or we set up the appointments at another healthcare provider's office, just piggybacking on their facility. And so I think harnessing technology is one thing, but it's also, you still have to be able to work creatively within the restrictions of the person you're working with and the community that they're working in.
And sort of a companion question to that is, what policy changes do we need to better utilize the technology that we just heard about?
So with respect to telehealth, I think the pandemic created an opportunity for lots of experimentation with various policy changes. So I think one of the changes that was made during the pandemic that many payers have continued is sort of telephonic only, and also payment parity for telehealth delivery, which had typically been reimbursed at a lower reimbursement rate than in-person care. And you've seen a massive and probably permanent shift to delivery of telehealth for some services. I think where we've seen this the most is in behavioral health care. The majority of mental health treatment, individual psychotherapy, and now increasingly large share of substance use treatment is delivered via telehealth. But yeah, there are still some technological and payment barriers to its full uptake.
Can I add one thing to that? There's also regional barriers. When we were still in the COVID pandemic payment model, I could see anyone in Ohio and in New York. That has changed, and now I have to see them in person before I can see them via telehealth. So it really reduces the benefit of using telehealth to improve access.
Thank you. We've heard a little bit of an answer talking about some of the underserved communities, about the refugee population here in Pittsburgh, and thinking about immigration. Very broad question that we can sort of narrow down as we speak, but what impact do immigration issues have on healthcare? And we know this is a hot topic for the election as well.
It is a hot topic, and it's so impactful. I'll offer just 3 very fundamental ways to sort of set the stage, and then if there is other conversation, we can go in those directions. But think about supply of clinicians, demand for services, and then financing. Those are very fundamental things. Immigration impacts all of them. For supply, it may not surprise you to think about how many immigrants come to the country and work perhaps as nurses. I'm a nurse myself. I think that's sort of in the popular knowledge. It's actually a smaller percent than some of our economic peer nations. We recruit far more physicians as a proportion of our population who are foreign educated than, let's say, the average peer economic nation. So that's really important. We also have, of course, unlicensed assistive personnel, immigrants who are filling those really, really important roles. So that's supply. If we think about demand, this is another fact that won't surprise anyone here. Our nation is aging. We have an aging population. And a large part of that is because the growth of our nation is in decline. And so our natural increase, meaning births minus deaths, is not strong enough to continue growing the country alone. If immigration stopped today, our country's population would begin to decline right away. And so we really rely on immigrants to continue growing the country. We have some hint of what that might look like if immigration stopped in terms of population dynamics. If you're familiar with demographic pyramids, trying to keep that from going inverted, right? Where you have a lot of weight on the older populations who are higher utilizers of healthcare, right? So immigrants are coming in, they tend to be younger, they bring down the average age of the country. They also tend to be less demanding in terms of the goods and services that they consume. And so there's some myths around that. But I've seen some statistics that say, well, if low-income Americans utilized healthcare at the same rate as low-income immigrants, Medicare would be 40% or more smaller. So that's substantial. And then the last bit is financing. It's so important to have a growing population, to have a younger population, people who are working, who are paying into these programs. Medicare, you mentioned the pay stub. It's not just payroll taxes, but general revenue. So any taxes that go into the system come out in Medicare, in Medicaid, and in other programs that impact health in perhaps less direct ways. So absolutely hugely important. And it's definitely part of the debate today. And so navigating that can be tricky, but hopefully those are some fundamentals that can help. Thanks.
Thank you. So I want to talk a little bit about the community needs. Again, we're hearing, cost and financing and there are access questions, but how do we make sure that what we're doing as clinicians, as policymakers, as people in the community, serving the community, how do we make sure that we match what the community needs?
Okay, so I can start with that. So within sickle cell disease, sorry, I'm going to use that as an example because, sorry?
Oh, I think he can't hear.
You can't hear me? Can you hear me? I'm speaking.
I think he's
do you want me to use this?
Yeah,
okay, sorry. Oh, I don't take it. Hello? Is that better? Oh.
I think
it's on. Okay.
Yeah.
Okay.
You're good.
So I was saying that a lot of my examples are going to be through sickle cell disease because that's my perspective. And I think sickle cell disease is a perfect use case when we think about health disparities. And when you think about health disparities, it's really important to understand the community and their needs. And so some early research that I've done was collaborating with a community benefit organization. That was my first time ever doing that and realizing how important they are to a community. They are the patient gatekeeper and they provide important insights into research. And through that, I think you're able to perform research that is clinically relevant to patients. I think sometimes as well as scientists, you fall in love with the science, but when you're looking at outcomes, does that outcome actually mean something to the patient? Is it going to improve their life? Do they care about that as well? And so the next thing I will say is that a lot of conversations around clinical trials and making sure that we are including patient perspectives in the implementation, in the design, in the development of clinical trials, because these are important trials. They set the stage for the treatments that are used and who gets approved for them. And so if we're not careful in including diverse patients and the patient perspective in that, then we can exacerbate disparities in the real world. So I would say to answer that question is to really make sure that you engage the patient through patient-reported outcomes. And an example also of that is in sickle cell disease, they actually are conducting clinical trials where they include the patient as a part of a consensus panel with clinicians and researchers. And these patients are able to help in designing clinical endpoints. So yeah, the short answer is just to make sure that you engage the community and get their input.
Just to add a little bit, in our region, for example, the mayor's office has an office, and we have a committee. It's called the Welcoming Pittsburgh Committee, and there are a lot of community members. So that's an example of how they can hear what the community really needs. So the worst thing we can do is to plan something that is not what they need, because we're going to spend money, we're going to spend time, we will prepare for outcomes that won't be there. So we have a few examples of other committees. UPMC also has a partnership with communities, and depending on the region, they have monthly meetings. There is one for persons with disabilities. So the key for this answer would be to listen, active listen to what they need, so you can build something that will be meaningful and important for them.
Anyone else in the panel want to chime in there? I want to circle back to the technology question. So we talked about telehealth. But what other types of technologies can benefit some of these communities that we're talking about?
For me?
Yeah.
Oh, okay. Sorry. I think there's multiple. I mean, many of them we use every day, right? Our voice-activated light switch, right? So if you can consider a patient that maybe has a spinal cord injury and doesn't have ability to use their hands, they come home, they can use a voice-activated light switch, voice-activated phone to control their television, etc., to contact their physician, so they don't have to go into the office for visits. As a clinician, we're beholden to our Epic inbox, but that's a technological advance that has been really nice. Now my patients can reach out to me every single day and let me know if there's something that I need to contact them about. And so that's been a huge advantage for patients to be able to use their voice and let us know when something's happening that wasn't possible a few years ago.
That's a great example. And it's, oftentimes we think about like the digital technology and sort of sophisticated technology, and not necessarily thinking about some more, for lack of a better word, basic uses, and sort of those activities of daily living. Thank you. So I think we all know that our healthcare system is a bit fragmented, and it's challenging in that way. And so a question about how do we coordinate the care within this fragmented healthcare system, and how do we overcome those challenges? I don't know that we're going to come up with the answer here in this panel, but maybe we can have some suggestions about that care coordination.
Oh, yeah.
Okay. Yeah. Hi. So one of the things that's been very useful is to make sure, and we've talked a little bit about this evening, is to make sure you engage with the community first. So some of the things that can be done would be to have open house or welcome forums or conversations with the community by reaching out to the local businesses in that community, reaching out to the local churches and places of worship in that community, and also making sure to engage in conversations about what are their needs and putting those needs first before ever implementing anything else. Statistically, and if you want to look at geographically, if you're looking at doing research or grants, you could create heat maps for the community to see what their needs are. So we know that most hospitals and clinics and allied health services that are provided have zip codes, and you could see where all of them are populated. If they're within the neighborhood, that gives us an idea of what services are available to that community. If they're not, that helps you understand that is probably a need that needs to be looked into. And Another thing that can, and on top of that, is create relationships with non-for-profit organizations that want to donate or provide endowments to whatever you're trying to put together for the community. And the whole time, it has to be speaking with the community, getting a pulse of what their needs are first, and then reaching out to those local organizations to see if there's any financial contributions that they would like to do to contribute to try to provide those services as needed. And then also reaching out to the local universities. Universities are wanting to do more community health. So if there is a university or institution nearby, that is an avenue to go into asking with those schools, with those institutions, to see if they'd like to partner in providing community health for the neighborhood that you're wanting to serve.
Anything to add there, Max?
So I'll speak from a clinical side of this. I want all of my patients to get everybody on the same page, working for them, everybody working in the same direction. And that's really, really hard all of the time. So part of my work is street medicine, taking care of people that are rough sleeping in the city of Pittsburgh. If I go out and take care of somebody, it's very likely that I'm one of 4 providers that is caring for them, all of us using different medical records. So that's, how do we even try to communicate together other than picking up a phone every single day and saying, hey, I saw so-and-so, and trying to plan. But even within more of a traditional hospital system, folks are not going to one system to see a provider. People go where they want to go. They see doctors, they see nurses, they see therapists that meet their personal needs. They're not seeing somebody just because they work for UPMC or work for AGH. They want to go where their providers are. And our healthcare systems don't really communicate that well together. And so I think the real answer is single payer. But since we're not going there.
I was going to go there.
Well, I should say, since that's probably not going to happen, but maybe, I don't agree. But yes, I think single payer is the real answer. But what we really need is to convince, is advocacy. We need to convince our systems, our hospital systems that are working today, to hire more people that do this kind of work and not just hire people that make them money, right? They're going to invest a lot in doctors and nurses and other people that can bill and make money, but we really need to invest in community health workers and social workers and medical navigators, because that's who's going to kind of close this gap for our patients. Even if we are single payer, that's what's going to close that gap.
Yeah, I was just going to say that a big reason for the fragmentation is the multi-payer system that we have. If we can't even really call it a system of systems, and the fact that people might change insurance plans every 21 months. And so no insurance company wants to make investments in long-term preventive health that will save money down the line for some other payer. And even if people are not changing their main source of coverage, Medicare, Medicaid, private insurance, they may be dealing with 2 or 3 different managed care organizations with different provider networks, depending on whether they're talking about the physical benefit or the long-term care benefit or the behavioral health benefit. So multiple sources of financing really complicate our ability to coordinate care. And have us working at cross purposes in terms of how the system is meant to perform.
So I'm going to ask the question that I already asked, but in a little bit different way, about paying for this care. So not so much just for the underserved, but we're talking about single payer. We're talking about taking away this fragmentation. But so what are some suggestions for how to pay for that care when we don't necessarily have necessarily the health plan or the insurer buy-in? This is an open question. This is an on-the-fly question for the panel.
Can you say that again?
Sure. It's how do we pay? You talk about single payer. How can we pay for that when we don't have necessarily the buy-in from the insurance plan? So single payer is obviously thinking about the government as the payer, but we need to get to that sort of incrementally. So I guess what are some novel suggestions for getting there?
That question's a little different than how do we pay for it.
Sure.
I'll draw the distinction by saying that in the first case, I interpreted it as, where are we going to get the money? Right. And then the second question is, how do we get to a system, single payer being an option for pooling risk and then distributing those funds? I like to think the money's already there. We spend way more per capita. You could look at it anyway, $4.5 trillion, and that's an old number at this point. On healthcare, it's larger than the third largest economy in the world. I mean, it's close, 3 to 4% of the world's GDP is spent on healthcare in the United States. So the money's there, right? And, you know, in my class, we often look at the iron triangle and we say the iron triangle proposes that you have cost, you have quality, you have access. You can't have all three. If you reduce cost, you can have quality, or you can have access, or you can improve those two in equal measure. But you can't have all three. You can't have low cost, you can't have highest quality, you can't have fully accessible care. And you know, the model's interesting in theory, but it just doesn't hold up in the US. We're pouring money into this, and then you look at the return on investment, and some of this is what we're talking about today. Very poor access. In some cases, there are exceptions to that, right? It helps to be wealthy in the United States. And then quality of care. Access could be a dimension of quality. There are other dimensions. Whether it's equitable is one of those, and I think that intersects with a lot of what the panelists are saying. So I like to think the money's there. It's probably mismanaged or put in the wrong places. So then, okay, if we all accept that answer, then the rest of the question is maybe closer to the single payer direction of inquiry here, which is how do we get to that? And those are policy questions intersecting with a lot of cultural hurdles, let's say. One of them being the historical fact of employer-sponsored insurance in the US, which we just expect now as part of a good job, and it's sort of an anomaly, at least in most of the world. And I think culturally that would be a real hurdle to give up in favor of a single-payer system. Single-payer system would almost certainly be the government, and a lot of cultural pushback around that, suspicions around the government, whether it can manage it effectively, whether cost, quality, and access would be favorable under those conditions.
Yeah, just to add something really briefly to that, I completely agree with my fellow panelists that there is enough money to go around, and would say moving to a single payer system won't automatically fix the problems and reallocate resources. What we have not had the political will to do is to ration care on the basis of cost and cost effectiveness. Instead, we have rationed care based on the ability to pay, which has created huge inequities in our country. We have the very best of technology available, if you can afford it in this country, and 20, 30-year-old technology for people who can't. And that problem, that resource allocation problem, will only be addressed if some people are willing to give up what they currently have to benefit the whole. And we're not there yet, culturally or politically, but we could be if we wanted to.
I just want to add a different way of thinking about where the money is coming from. Sometimes we are spending money that we could be saving, and now we are thinking about sustainability and the environment. There are so many ways we can save money. The way we do in our healthcare system, we spend so much more than we should. So really we need to assess, analyze, and see ways where the money that is for sure there, we could save to implement in other measures, and especially preventive measures that will save us even more money.
I think it's a really important point about the money's already there. One of the readings I assign my students relates to how to fix the healthcare system and offer suggestions like single payer. But the last one is we're already doing something right that other people aren't. We are already spending a lot of this money. So it's a really important distinction there, that it's not that we have to find those sources, we just need to reallocate them. Now, the last question I'm going to ask our panelists before I open up to the audience is about navigating our current landscape in an informed way. I think we're all familiar with the idea of misinformation and disinformation and maybe a lack of understanding of all the terminology out there in the healthcare space. And so it's, what do we do, and how can we help the communities that we're working with to navigate the system in an informed way?
Well, I'll jump in there because I think that is a great segue. We're already talking about single payer, and I think that's an example of a term that gets thrown around, and we've defined it a bit here, but it gets thrown around with other terms that are sometimes used interchangeably. And some of these terms mean something, and others something specific, and others mean a number of different things. And so I'll just highlight a few. I think it's helpful to start with universal coverage, and we heard that on the panel today. What is universal coverage? Well, it's not really a plan, it's a goal. And it basically recognizes healthcare as a universal human right. And we say, hey, everyone should be covered. There could at least be a practical reason for that, right? We can think of practical reasons aside from the human rights argument. So everything else kind of fits under that. The Affordable Care Act, universal coverage or getting closer to it was a goal. Certainly in concept and in implementation, it's fallen short of that a bit. But, if you watch the last presidential debate, Trump was pushed for a plan, and I don't think he had a good answer to that. He basically admitted he didn't have a plan, but he said something really interesting to me anyway. He said, well, I'll have a plan when I have a better idea. And I think that's kind of where we are, is no one's calling the Affordable Care Act perfect per se, but it's hard to think of a better idea sometimes. And especially if you take into account needing the political will to pass something, to make it politically feasible. So, okay, universal coverage, we have the Affordable Care Act, we have CMS, these are major political reforms. Well, single payer can be part of, it's a bit more specific, it's part of a plan or a version of a plan to get towards universal coverage. And essentially it says replace all the existing insurance infrastructure with one insurance company. Probably the government would run this. So you have the benefit of a huge risk pool, less fragmentation. Julie mentioned a few things here that are benefits of single payer. Another option is what's called a public option. And so this could look a number of different ways. Again, this doesn't refer to any specific plan, but is sort of a category of plans. So a public option would be like an expansion of Medicare. You've heard Medicare for all. Again, another term that doesn't really refer to one thing in particular, but could be a version of single payer, where you expand Medicare to replace all existing plans, or you expand Medicare to compete alongside other options such that everyone has a government-funded and run insurance program. Actually, the run part is another variation. I shouldn't say that's a universal quality of public option. And then the last term, and this one can kind of be, I think it has a lot of baggage with it, but is essentially a form of socialized medicine. So you have the government not just administer a health plan, but also employ the physicians, the nurses, all the employees, and manage the healthcare delivery network. And I think some Americans will bristle at that, right? There's a cultural response to that. And sometimes we forget that we sort of already have that in the VA. We've heard already the VA, some good qualities there. The Indian Health Service is another one that's at least very close, or the closest thing we have in the US. So variations of existing things that we have in the US, the patchwork of our coverage that could be adopted and expanded or adopted and modified, lots of different ways those look. But when you hear these terms, and you'll hear them a lot through these debates, they don't always mean one thing. So it's important to sort of dig down and see, well, what are the details? But hopefully at a categorical level, I've helped you sort of sort these terms into different buckets.
So I'll just add thank you for that. I want to continue to add to what Andrew just stated. So one of the things that would be exceptionally helpful is to also do your own diligent research into health policy and how that affects your communities. Also looking at Also researching the communities that you want to target and work with, making sure that you're aware of their culture, you're familiar with their way of living, and also making sure that you're addressing their needs. Definitely separate the lies from the truth. Right now, we are hearing a lot of vitriol about communities that are not true, and and puts a target on those communities. So making sure that you're doing your background and diligent research on what is the truth versus a lie, not to make assumptions. Also looking at food disparities. What access do those communities have to food, to healthcare, to socialization, those types of things. Transportation, access to how those communities are traveling and traversing to go to work and school and home, because transportation is also a barrier to access sometimes. And also research the health insurance policies that are available. As we know, health policy and health insurance have stipulations on, what healthcare the person is coming into, what healthcare they have access to, any type of health conditions that may be preventing them from accessing their healthcare needs. And make sure to, again, not make assumptions. That's the main thing. I think we all come into a situation with a thought or an idea, but make sure your thought or idea is not an assumption, but base it on fact, and look at people and treat people the way you would want to be treated. And that's the main thing that we all walk into when we work with our communities.
Great, thank you. That was a great way to segue into our questions from the audience. So please, I believe there's a microphone here. If you have questions, please come up to the microphone.
Hi, I have a couple questions for a couple of you guys. One was a comment that you made. You mentioned that immigrant populations tend to expect less of healthcare, and that you quoted a number that was like, if the majority of low-income population utilized healthcare in the same way that immigrant communities do, it would be smaller. What did you mean by that?
Their consumption is lower. So it was in the context of demand, thinking about our aging population. Older people tend to demand more services. So that's a burden, in a sense, on the healthcare system. And I think sometimes we jump to conclusions thinking, oh, immigrants are only going to increase that burden. But in fact, their utilization rates are lower.
Would you argue that that's because of the lack of access within immigrant communities?
But it's true, and I was thinking that to myself up here, like, yeah, that could be part of the problem. It's like, maybe they don't have access, and if they did, if we increased access, their utilization would go up. Yeah, it's very complex. So great thinking, but yeah, you're absolutely right.
Okay, I have another question for Max. I'm interested in the idea about like street medicine. How do you make sure, like, if you work with people around Oakland, like I recognize some of the like houseless people around Oakland because I live there. Do you interact with people like on the street? Like, do you just see people and you're like, oh, this is somebody that I think needs help? Do you approach them? Do you let people approach you? Like, how do you make sure that they know that you're a safe person to approach and that you will be able to give them the care they need without being dangerous to them?
It's not easy. I think there's a few questions there, like how do you approach people that are homeless or maybe homeless and make them feel comfortable accepting healthcare?
I was more just kind of curious because I don't know that I've ever met somebody who like is very specifically focused on providing like healthcare to
Awesome.
houseless people.
So that's awesome to hear. So I'm not unique. Street medicine actually started in Pittsburgh with Dr. Jim Withers. He started this about 3 decades ago. And he started an organization called Operation Safety Net. And so that's still based in the South Side. And Jim and he has 2 nurses that work with him round regularly to take care of homeless population. We're really blessed in Pittsburgh. There's actually 4 street medical organizations in Pittsburgh, as well as multiple outreach organizations. And so hopefully that highlights the difficulty in coordinating care, but in some ways we're also blessed because there's lots of organizations. As a result, the community in Pittsburgh has a lot more understanding that people that are coming to them with medical care are there to provide, hopefully, I should say, hopefully provide safe medical care. And there's some basic tenets of outreach, and doing our best to provide trauma responsive care is important and key. And so I'd say that I think everyone that does it really tries our best to do that. We don't always succeed, but we do try our best.
This is just like a me curious thing, but are there any safe like injection sites in Pittsburgh? Like I know that's one aspect of like harm reduction for houseless people specifically with addiction is like making sure that there's safe centers for healthy like making sure that people aren't getting infections from injecting if they can't, have access to rehab or anything. Are there any of those in Pittsburgh?
So the county of Pittsburgh and Allegheny County partner with an organization called Prevention Point. And so if you have any interest in kind of harm reduction, definitely look them up. Prevention Point, if anyone else is interested in harm reduction, are a phenomenal organization. They provide supplies to multiple other outreach organizations in the city, and they have drop-in locations, I think 5 days a week all over the city. They have a mobile unit as well as a permanent location in the East Liberty area.
Okay, so, I live near East Liberty, so that makes sense. So I think I've heard it before. But
yeah, so they do lots of different kind of harm reduction practices, including wound care. So if you know someone that needs to see them, they have wound care providers on site as well.
That's good to know. And then I have one more question for Adriana, which is that you mentioned that within healthcare systems, like there is a lot of cost that can be cut. Like as somebody who works in like the School of Dental Medicine, is there any like specific cost that you can think of just off the top of your head that is like an unnecessary cost that could be cut to put money towards like making sure that more people have access? Like you mentioned that like in a broad sense there was, but is there anything like off the top of your head that you could list?
Yeah, you probably heard there was a call for the sustainability project requesting ideas. So if you think about dental, I can give you an example that all the toothbrushes, most of them, they are plastic toothbrushes. So we could save a lot of money if we have alternatives to provide to our patients. The problem is, again, people are not creative because they don't think about all these little nuances that you can have in your own profession. I love your question to Max about street medicine because I can give you example of patients that we work together. So at the dental school now we have a street dentistry club and we go with them to rounds and the dental students provide information about oral cancer prevention. And many times I'm the person who is on the rounds and I bring them to the dental school and I'm kind of, sometimes they have insurance and sometimes they don't. And most of the times they are in pain and we have an emergency clinic. So we try the best we can to make them safe. And asking about your question about the safe, there is a 412 youth zone for LGBTQIA youth, and it's a drop center. You can just go there and there is trauma-informed care and nurses and pediatricians, and it's a very safe space that they can go. And they usually go. We are working there on Tuesday afternoons, and we have almost every week between 20 and 25 youth that they feel safe to go back, and we work with them, and then oral health is very important for them.
That makes sense. And I'm sorry I'm taking up all the time. If anybody else wants to ask questions. Which is one, like, you were mentioning, like, doing your own research. Do you think it's, like, this is just from my experience, like, do you think it's fair to ask the, like, average person to do the research on their own? Just because, like, as I'm, like, a student and I'm, like, a lot of people around me are either, like, still on their parents' health insurance or, like, now seeking out different forms of care, either getting insurance from their job, like, shifting around and figuring out the healthcare system. Like, there's a lot of confusion. Mm-hmm. Do you feel like, I know that, like, that's what we have to do is look it up, but, like, I don't know, do you think, just, like, off the top of your head, is there any, like, do you think that, like, a large-scale collection of anything like that would even work with, like, the fragmented system that we have? Because, like, one of my friends was looking for therapy, and, like, she's looked at like 80 different little things, and none of them take her insurance, but she has to like do all this digging to figure it out. And so like she still is like, she doesn't have therapy, but she spent like 4 hours of her day and she didn't get her homework done because she was looking for it. Right. So it's like, would a large databases like that even work? Because there's so many like small companies that do small niche things, or do you think it's like actually feasible?
Okay, so great question. Great questions. So I think when I say do your research, so example, your friend is looking for a clinician, and you know she or he is looking through their insurance policies. One of the things, I'm sorry?
Oh, it's she. Yeah.
Okay. So if she's looking through her insurance policy and she's not getting the resources that she needs, one of the things that she can do is call the insurance company and ask them, well, I live in this area. Can you provide me a list of therapists? Make the insurance company help her. So I do it all the time. And that's a resource that we often don't tap into. We go into the health, and also the insurance company who doesn't want to do the work will tell you, well, look at your manual. Well, no, I don't have a lot of time to do that. I need for you to help me, and I'm a payer in your insurance company, so I would like your help. Okay. And the insurance company will say, okay, well, what zip code do you live in? And they can send you that list. So when I say do your research, just look if that is something that you're wanting to do. So I'll give you an example. The School of Health and Rehabilitation Sciences has we have a community engagement center in Homewood, and in Homewood and within that community engagement center we have something called the Wellness Pavilion, and we've just started providing free therapy services, clinical therapy rehab services at the Wellness Pavilion starting this fall, and that was my project. So from my office. So what I did was I did the research for the community, and I prepared that for them because it was first I needed the buy-in, right? Make sure that's what they wanted. We had those conversations, and then making sure that these are the services that they needed. So it would be good to partner potentially with organizations, not-for-profit organizations that have already done the research that can help keep you informed. And that's something that was helpful to me because I was able to access and tap into that. But again, I'm coming at it from a research lens. So from a student lens, there are community partners that you can talk to and ask. They've done the research, believe me. The research is there. It's just who wants to know about it, and they'll share it with you.
That makes sense. That was an unexpectedly poignant example. That was your research and your project. Okay. That's all my questions. Thank you, guys.
Thank you.
Thank you. It looks like we have another question here.
Great questions.
So it seems like research and public opinion is having less and less impact on the actual health policies and legal decisions surrounding health that have been made recently. Do you guys just want to comment on what you think has led to that and some steps that can be taken to reverse that? Thanks.
Well, we're being recorded, so.
The PG version.
The PG version is that politically it makes sense to cause confusion. And if you cause confusion and chaos, no one knows what to think. It makes everyone nervous and anxious, and it makes it easier for you to believe, insignificant comments about specific communities. It's easier to point blame at other communities instead of looking at yourself. And you are right. Facts are losing power in what is real versus reality TV. It's becoming like reality TV. So we have to shift the needle of redirecting people to facts. And that's going to take time because the needle has been shifting everyone to look at things from a fictitious lens based on whatever propaganda is being pushed on us politically, and we're being used as pawns in this. So to answer your question, I'm not sure what the answer is, but we just have to continue to speak the truth into facts and redirect people into doing their research objectively versus based on emotion, based on bias, based on racism, based on sexism, based on every ism that comes with it. And that's something we have to continue to be more vocal about. I think that fact finders and fact speakers are feeling so overwhelmed with having to deal with all of the chaos that we've just been quiet. We have to be loud.
So I really appreciate your question, Donald. A very difficult question to answer. To try to be a little bit more hopeful, I think there's a lot of dysfunction in our politics nationally that creates no incentive to solve actual problems facing people through policy. I do think, at least in some state governments, there is still an ability for representative democracy to work more functionally than it is at the federal level currently. I also think that researchers have a lot of work to do to make their findings digestible and actionable by policymakers. We tend to publish for one another and to get promoted and to get the next grant, and not necessarily to realize policy change. In order to do that, we need to develop relationships with policymakers. We need to make our 3,000-word complicated research paper into a one-page policy brief. We need to have conversations, and we need to engage communities in bringing stories to the statistics that we're generating in our research studies. And I think we often fail as a research community to take those steps. So we can't just blame it on dysfunctional politics and politicians who aren't listening to the evidence. We have to fill that void more effectively.
Could I add one more thing? I think one of the reasons, and there are many, but one of the reasons that we often feel like we're talking past each other in the policy process is that we jump to solutions without really getting on the same page about what problem we're talking about. And so, I think one of the really hot topics today, of course, is abortion, right? And I'm not going to wade into the weeds there on either side, but you could say abortion is a problem. That's not really a problem statement, and either side of the aisle could say it, right? And that sort of illustrates the point. So if we need to think about, well, what about it is problematic? And can we boil this down to, on the one side, maybe it's an issue of bodily autonomy or rights around that. I mean, I'm not saying that's a great problem statement, but boil it down. Like, what about it is problematic? And on the other side, it might be a human rights argument. So you can keep distilling on either side. My point is, when you go to talk to someone and you want to be persuasive, it's helpful to find a problem that you can agree on. And there are things about even that very divisive issue, I think, that if you spend enough time thinking about it, you can at least understand how they view it as problematic, going either way. And then you can really begin to think about, well, okay, what policy issues could address that specific statement? And that can be useful for framing policy briefs. Don't frame it around this big amorphous issue. Frame it around a discrete problem. You can tie your policy directly back to that. You can have a measurable impact on the way that's stated. And then you also frame the conversation in a way that, okay, we've agreed on that, so now we have a point of departure, and we can work through whether we can agree on something that is politically feasible, and without deciding whether it actually addresses the problem, because hopefully through research that's more demonstrable at that point. You kind of clear the playing field a bit. That's one piece of advice I'd offer.
I think we have another question.
I was wondering, would there be any benefit to like non-physician, non-APPs billing for their services? Because my understanding is like hospitals see the doctors as like they're generating the revenue, they're, billing and such, and like nursing, social work, they don't necessarily like bill for their services. Just any thoughts?
Are you in my class? We just talked about
but maybe I should be.
You speak as if someone who just attended a recent lecture. So anyway, I'm not going to answer the question necessarily. Okay, I'll jump in there. Okay, yes, in theory, yes, I think there's a benefit. It ties nursing services, to use that example, to revenue, which takes them from, put your CFO cap on, takes them from being a cost where you're just rolled up in with the cost of a bed, things you want to cut to increase profit, to now you're generating revenue. And so that is a big shift. I have colleagues who argue that would be very decisive in helping hospitals, for example, value nursing and not do things that are maybe counterintuitive to nurses ourselves when we say, well, why are you cutting staffing if you want to improve outcomes or whatnot? I think the counter argument, or one of them anyway, would be administrative costs. We've talked about administration being one of the reasons for bloat in healthcare and high costs. I think that only increases that burden. I don't quite know which way the balance tips, but I think we need to keep both in mind. Thank you.
I had 2 questions. First question, in this incremental approach to reform healthcare, even what we currently see is that many healthcare workers are experiencing burnout or are not getting reimbursed fairly for their work. For example, we have a large focus on procedural work rather than preventative care. So I was kind of curious in this incremental approach to reform healthcare, your thoughts on workforce protections, how to, like one strong thing right now is labor unions and whatnot. So I was kind of curious on in the government, what level do you believe workforce protections can be best, and some other examples of workforce protections as well.
I do have some thoughts. Oh, go ahead.
Well, one of the things I can say with to address burnout is what we're doing at the Wellness Pavilion is we're providing students a clinical experience. So we're making sure that the professors and clinicians that are coming to the Wellness Pavilion to provide services are supervising students, so it's not so directly, burnout is real, it's going to happen, but giving those students clinical experiences that look at the well-being of the patient population, which also offsets the burnout potential for those providers. So it feeds itself because the students are getting the experience that they need, and the supervisor or clinical educator is getting, being able to provide a teaching opportunity for those students, and they're also not directly providing those services. So it helps with that burnout. That's something that's been working for us, and it's cyclical because then those students, when they matriculate to the next semester, can supervise, can help. Like we're creating with something called junior clinicians, where they're providing those services to the incoming students and teaching them. So then there's less cost, emotionally taxing, everything else, professional cost on the provider, and it gives the student opportunities to then teach the incoming student. So then it cycles out. So that's something that we're trying to do to make sure that we're preventing the burnout.
I thought it was interesting you talked about unions, and when you look at the literature on nursing unions, just broadly, what is the impact on patients, on nurses themselves, on the administration? It may be no surprise that over 20, 30 years of this literature, most of it looks at wages, and probably because the people interested in these questions traditionally are economists, and so they go to wages. And to be fair, in a lot of other industries, that's a primary bargaining chip, right? That's what they want out of the negotiation. When you look at nursing unions, the impact on wages is much smaller for nurses. It's a little larger for lower wage, lesser skilled employees in hospitals, for example, or also nursing homes, although less work has been done there. And relatively little work has been done on nurses themselves, things like burnout. There's a little bit on it. But the point is that the research here is a bit misaligned, because I think what's happening is that nurses, when they unionize, wage is not necessarily a priority. It may be part of what they want. They may try to get a bump, and it seems like they do, but it's small. But we just don't know, well, what are they bargaining for? Well, it's probably things like staffing or other factors of the work environment that do impact burnout. And so I have a group that we're doing some work looking into this, and so stay tuned. Maybe we'll have some more answers for you. But I think it's an interesting line of inquiry, especially as you connected it to unions. Thanks.
Thank you.
Oh, I might add one other question, if that's okay. In terms of health communication, how do you educate and express optimism to either patients or coworkers who can, see the worst of healthcare, or as many of you are working with social safety net patients and whatnot? How do you educate optimism or communicate optimism to those patients?
Okay, I guess I'll go. One of the things that has been helpful for us is seeing the positive change in well-being for the patient population. That also, it pretty much feeds my soul when I see it happening. And I think that also, and seeing also the students, how engaging and how much they love working with a population that they may not have had access to before. So seeing that growth and that potential is something that has been beneficial for us. And also looking at outcomes of the patient population to see that there are improvements over time. It's not going to be, overtly obvious in the first, week or two, but over time you do see that positive change. So seeing that extrinsic change seems to make a positive impact. So knowing that what you're doing is providing a contribution, not only in your skill set, but also to the people you're engaging with. So sometimes that's helpful. I mean, there are going to be times when there are dire things that you do see, but there is a benefit to seeing the good that comes of it as well. So
I can add to that. I think goes back to as well as engaging with the community stakeholders, community benefit organizations, hearing from patients, having that bi-directional communication. I think one of the things within my research when I was working with the community benefit organization, a lot of times research refers to individuals with sickle cell disease as sickle cell disease patients. And the community, they're called warriors. They like to be called warriors. So having that insight and information and communicating that within, whatever you disseminate to the community or when you're in conversation with them, that's impactful. So.
Great example. Thank you. And we have time for one last question.
Hi. I had a question kind of circling back to the discussion of the fragmentation of our healthcare system, and kind of one way that we can work to overcome that is by hiring more people in positions like social work and community health workers. And just kind of, looking back on my experiences from an FQHC, these are jobs that are, historically very difficult, mentally taxing, often extremely underpaid. How can we as clinicians and student clinicians, I'm a medical student in the first year, what can we kind of do to advocate for better conditions and more funding for these very essential workers in our system? Some just concrete steps.
I can give it a try on this one. I don't think we should undersell at all the advocacy that comes from students. It's amazing. So Street Med at Pitt would not exist if it wasn't for public health and medical students that started the organization a few years ago. And some of the students have gone on to graduate and are working full-time in homeless healthcare at this point, which is totally awesome, right? This is amazing what students have done in this area. The same students that have been part of this organization are working to write grants to get our hospital system to hire more social workers, to hire community health workers, and working with leadership in our insurance division to help provide us with those resources that we need. And so I think really important to not, to think that this is dire. There's always ways that we can improve and provide the folks that we care for with the care that they need. And as that last question was, to have hope with all of this, right? This, being able to, be there for someone and provide them with care it really is a hopeful thing, and it really is a wonderful thing and wonderful experience. So
I just want to add, one of the things that has been helpful in what we've been doing in Homewood is making sure that we come out of our siloed schools. So I'm our school is working with School of Dental Medicine. We've reached out to Max actually, which is great. And also School of Pharmacy is working with us as well, and School of Social Work. And we're working collaboratively together. And I think if we have that type of communication as an institution, it benefits the community. Because when you ask the community what they need, and for us, the first thing that they asked for was counseling and behavioral health, and which is a program that we have in SHRS. But that's not enough. We also need to include social work. We also need to look at, not only their physical well-being, but their mental health. So we are making sure to focus on that. And working outside of your siloed thinking is also important. Being creative.
Yeah, I think there are huge issues around how to increase the supply of community health workers, big policy questions about how do we credential, train, monitor, and finance community health workers in a variety of settings. And I think the kind of long-term strategy has to involve evaluation and experimentation. So that we can provide evidence that these are really important resources that don't just add to the budget, but improve outcomes. And I think that's been demonstrated for doula care. And we're now starting to see many state Medicaid programs add doula services to covered benefits. But then there are really tricky issues around implementation and moving what is often informal financial arrangements between a doula and a client to a much more highly regulated environment in financing. So really important question, and I think a lot of important implementation and policy issues to be worked out there.
Thank you. And I had one last question. I'm sorry. And kind of going back to the question of having students work in these settings in student-run clinics in street medicine, which I think is wonderful, and I'm really glad that it's a thing because I want to do it myself. But I also sometimes wonder, students don't have the full clinical capabilities of a full clinician. And is there an ethical consideration when you have low-income or unhoused patients who would otherwise be seeing, be sitting in a facility that has more resources, more, more attention to their needs, and is there a disparity in care when they're being seen by these student kind of run organizations? And how can I, as a student, make sure that what I'm providing is ethically, and socially conscious, and that I'm not harming anyone in that process?
So I could speak to what we're doing. We train the students to work with the community, but also the clinical providers or clinical educators are on site. So they're with the student the whole time. So that community member is getting access to not only the student, but also the clinical educator or the clinical provider who does have the resources and has that skill set. So for us, it is an opportunity for growth, but also there is access when needed. So they're not getting, cheated, if you will, of seeing a clinical provider when, instead of a student. It's the other way around, but you know what I'm trying to say. Yeah. Thanks.
Okay. Thank you. Thank you all for attending today. Our time has ended. I want to thank our panelists for their insightful comments, and thank you for your great questions and for your participation. Please join us downstairs in the library for the reception. So there are some folks outside who will help direct you to the auditorium. Thank you.